How was it that you decided, Pascal, to include some of these variables over others? Was, in your systematic approach, you use broadly the term, we did a systematic approach and look for specific guidelines. But can you give a bit more detail on what made it in and why something made it in over something else that maybe didn't make it into the protocol?
Sure. I mean, it's over the last 20 years, I tried to improve my patient outcome with multiple aspects. I started by creating this local infiltration protocol of local anesthetics. And then after 15 years of development in different fields, I felt that I reached like a step that was a bit hard to go over. And I decided to go and visit experts in the field around the world. So I want to acknowledge the work of Rich Berger in Chicago, who is a great thinker. He's working on all these aspects for years. And what he developed in his practice is outstanding. But unfortunately, because of different reasons, it was not shared in the literature. It was not shared in the scientific community. And so this is one example. I went to visit surgeon in Italy, surgeon in Europe, and I came back home with my anesthetist, my physio, my nurse, and we sat down and we reviewed the literature and tried to create this recipe. And creating this recipe, we had to decide what was ideal for a public Canadian system and may not be suitable for other countries, other practices, but we had to make some decisions. So what we presented today is our personal, let's say, cocktail, but maybe modified in other centers.
Yeah, that's actually very helpful. If anyone has a question, just let me know or unmute and I can quickly see if anyone wants to ask something. I see Walker.
I have a very simple question.
Sure.
Yeah, the dexamethasone, I assume that was IV, or was it some other way that you gave it? 4 milligrams for the diabetics, I think it was 12 for the non-diabetics.
If you look in the literature, there's multiple publications on dexamethasone. We prefer to give it IV at the time of anesthesia because when they receive the dose earlier, it can create some euphoria of the patient. So we want to give it once they get the sedation to avoid this a kind of hyperactivity given by the drug. And we tried to tailor the dose of dexamethasone according, as I said, for example, for diabetic patient, we don't want to raise their blood sugar too high. So we give 4 milligram. And we think that with 8 milligram, we achieve the, let's say, the impact of needed to improve recovery. Because you need to see the drug as a part of a multimodal protocol. If you look in the literature, sometimes they tested the drug, but only as a single intervention. And I know studies who used up to 20 milligram. But then again, it's a decision that you need to take according to the overall content of the protocol, not only as a single drug.
Okay, that's actually great. Any other questions? Aaron, yeah, go ahead.
Yeah, I had a question about kind of surgeon uptake. At our center, it was same day was kind of thrust upon us with COVID. So there were some early adopters, and then there were some other surgeons that were kind of, it was basically, that was the only option. And we've looked at our data and we have huge variation who's able to kind of successfully pick these patients. So I was wondering at your institution how you've been able to implement that and I guess persuade other surgeons and teach other surgeons how to properly pick patients.
I mean, this is a teamwork. Yes, first you need to establish some inclusion criteria. If you look at the one we are using, they're quite broad. And then the surgeon, when you meet the patient, as you probably do in your practice, we don't have an hour to question the patient. We don't know them really personally. So we try to select first the patient, say, okay, this patient is a good candidate, and then we book them for day surgery. Then when they come to the pre-op assessment, all these criteria are reviewed by a nurse, and she's speaking with the patient, see if he's a good candidate. And then from maybe my pickup, which is maybe 80%, we're losing maybe another 10%. So we finish up with a 70% inclusion rate. And once this whole screening is done, we feel that our failure rate is very low. It's about 5% of patients that could not leave on the day of surgery after going through this process. But you need to get the whole team involved. Yes, it is changing practice in many centers, the way you do things, but I'm sure that overall it's a great gain. All this investment will be profiting your organization for years, and the patient as well.
Great, thank you.
So we got a couple of questions. We got one from Vic Khanna. Vic, I don't know if you can come on to screen here and ask the question directly. If you can't, I can go. Oh, yeah, there you are. Great. Do you want to go ahead? And I see Pat Henry's got one as well. We'll go with Vic first.
Hey, Pascal. Good to see you. Sorry, I missed the first part of the talk, but cryo cuff I'm using a lot more with some of my day surgery patients. Is there any evidence for that, or is that just something that was that part of your protocol at all?
You mean about cryo compression?
Yeah.
Yes, we're using it for the knee replacement, because knee replacement, as you know, the pain control is a bit more complex than hip replacement, and we feel the patient also, you want to reduce edema and inflammation. So we are using the cryo compression during the stay at the hospital in the post-op period. And if patients want to use the cryo compression at home, they can rent the machine if they want to go on with the system. And it's hard, you know, all these addition of intervention, it's hard to know if they have a significant impact on their own. It's kind of a combination, as I said, you know, if you're waiting to find a study that will clearly demonstrate that cryo compression is a game changer, it will take time. The same as for not using tourniquet. You see in the literature there are dozens and dozens of papers randomized saying, oh, tourniquet is not bad, tourniquet is bad, but at the end, if you're adding all these interventions that will improve patient comfort, cryo compression, not doing tourniquet, infiltration, all these things are adding up together, and then you get an overall result.
Great, thanks. I see Pat Henry, you have your hand up. Did you want to come on video if you're, or maybe that's an accident? Well, while he's sorting that out, let me just, if I can, just jump in and ask a broad question, and then there's a couple of other questions in the chat that we can get to quickly as well. You know, a big feared outcome of total joint replacement, Pascal, is infection. And infection prevention and prophylaxis is a big part of it. In fact, our group at McMaster is embarking on a fairly large pilot, but 1,000-patient pilot, looking at various irrigating solutions in the, during that lavage period of trying to prevent infection, which will likely lead to a very large multinational trial. Can you speak a little bit about the specific infection control measures that you're using? And a couple that come to mind that I didn't see was, the whole influence of patient warming, and I guess secondarily, in patients with edema and potential wound issues, are you using sort of negative pressure therapy? I mean, those are the two things that are sometimes talked about. And I'm curious what your take on those are.
Yes, for me, the most important part of infection prevention are 2 points. First, patient optimization. Patients need to have their diabetes improved before surgery. You want to reduce anemia. You don't want them to be transfused after surgery. So this needs to be done before surgery. This is part of our ERAS principle. Second is the antibiotic prophylaxis that need to be done in the first 30 minutes before surgery. All the other interventions will have an impact, but it will be much more limited. I mean, if you do these two things, optimization and the antibiotic prophylaxis, you should be below 1% infection rate. So all the other intervention will need to be very cost effective to reduce below 1%.
Got it. Okay. So if you were to add to this protocol, and there may be processes for looking at evidence in the future, you'd be looking for ways in which you can incrementally improve upon the standards, which are antibiotic prophylaxis as one of the key, I mean, obviously one of the key measures, but you'd be looking to be thinking about those issues. So, and also the quality of the evidence, I presume, around that.
Yes.
Okay. A couple of questions here. Are these patients limited to the early AM slots? This is a question again from Walker, who was asking about the dexamethasone.
What we do is we needed to change the working schedule of our nurses and physio. So if we want the patient to be operated, for example, at after 12, we need a physio available up to 9 or 10 p.m. Because the patient will leave home at 8, 9 p.m. So this was a change that took time to get a time slot, a physio that would be available from in our center from 12 to 9. And then, so we do usually our first 3 cases of the day could be a day surgery. So until 12 or 1 p.m. It's fine. And then we cannot do the last case of the day at 3 p.m. And then within our selection, because we have 70% of patients suitable, then we can do 2 or 3 outpatient surgery and then 1 inpatient surgery in our OR day.
That's great. Thanks. There's a couple of questions here, one from a Richard and one from Mark. Either of you want to come on video and just ask directly the question to Pascal?
Hi, Pascal. It's Richard Kamiker here.
Hi.
Hi. I had a couple of patients bounce back who, with the drainage from the wound, who I treated with Xarelto. So, over the past few years, I've switched from low molecular weight heparin because patients didn't like to inject themselves. Then I switched to Xarelto, but found that there was too much drainage and a couple of patients bounced back. Then I tried aspirin, but I had a couple of complications with that. So I'm just wondering what your anticoagulation protocol is and whether you've had any specific complications related to drainage and coming back to the emerge, depending on the anticoagulation you use.
Great, thanks for that.
So we use the EPCAT 2 protocol, which involves Xarelto for 5 days and then aspirin for 9 days for knees and 30 days for hip. And with this protocol, combined with glue, skin glue, and a system of mesh and glue for the knees, we're sealing the wound. So wound drainage is really reduced in our patient. So we do not see patient coming back to the emergency. For me, the optimized wound closure is very important. We want to use a minimal dressing, only enough side visible. We want the patient to be able to shower from day 0 after surgery. So very unusual to have wound drainage with this, what I just mentioned.
Great, thanks. Any other questions? Oh, there's a question from Mark. Mark Hood, did you want to come on and ask? You just got to unmute yourself there. We're good.
No, Moët, it's very, I mentioned earlier, and I think it's an important point. As I said, a multimodal protocol. When we created that protocol, all the drugs that are included in let's say the preemptive medication and the intraoperative medication have been reviewed by our pharmacist, because there are a lot of interactions and a lot of potentialization of the drugs. For example, I will give you an example. we use aprepitant. Aprepitant will potentialize many drugs in the cocktail. So you don't need to use the same amount of a drug, because they combine together, they reach an higher level. And one thing that we learned when we start the protocol, we had some anesthetists who forgot that they could not use Versed for benzodiazepine. And the patient were sleeping for hours in the recovery room, and we did not understand why. And when you use aprepitant as an anti-nauseous drug, it double the amount, the effect of benzodiazepine. So this is just an example that if you're implementing ERAS protocol in your practice, please make sure that all the combination that you're using will be the appropriate level for each drug.
Okay, that's actually great. Well, I just wanted to make sure that, you know, we get all the questions answered. Any other questions from anybody? Oh,
Mo, I have a question for Pascal.
Oh, sure. Yeah, go ahead, Dan.
Hi, Pascal. Thanks for the talk. I'm Dan Tashinsky at McMaster. I've been doing same-day arthroplasty for about 3 years now. I find my biggest, sorry, my dog's barking in the background. I find my biggest barrier to same-day is the sleep apnea patients. What are you doing anything specific with your apnea patients, whether their severity is mild, moderate, or severe, CPAP compliant, non-compliant?
No, it's quite an interesting question, because this question was raised many times at the early phase of our protocol. And in fact, because we don't use opioid, patients don't take dilated hydromorphone, they don't take morphine in post-op. For sleep apnea patient, it is a safer protocol. They go home taking Celebrex and Tylenol, and that's it. So we don't worry with these patients, because they have no or very limited risk of complication with the protocol, which is opioid free.
You know, I mean, go ahead, Dan.
No, that's actually quite helpful. I was also going to ask just a bit of a follow-up question. Do you have different protocols for patients with chronic pain or methadone patients? Because I do find those patients, regardless of how I try to limit their opioid use post-operatively, I still tend to struggle with them. And so do you find that with your protocols, your patients who tend to be on high-dose preoperative narcotics or methadone, do you have any additional strategies for them?
Yeah, I mean, you're right. These are the most complex patient to take care. I mean, whatever, if it's an ERAS or standard inpatient. What I tend to do with, we did a lot of outpatient cases like this, and we tend to keep the same medication that they were taking before surgery, and we continue the same dosage for about 2 to 3 weeks post-op. So we don't add additional opioids. They just continue on what they were taking before surgery. And this was quite effective. And when I see them at 4 to 6 weeks after surgery, I try to convince them to reduce their chronic opioid use. And many of them, the ones who were suffering a lot from their joint, they say, "Hey, doctor, I was able to cut down my opioids by myself." So this is the most rewarding I can see with these cases at 6 weeks. But the trick is to try to keep the same pattern they were taking before surgery. And then I think that's the best way. You don't want to switch them and then to start from scratch.
You know, and we have very quickly reached the end of our session here. And, you know, we could probably talk for hours on end here, Pascal. But what we will do is we have this reported. We'll make sure we get this out to everybody else. And I'd also encourage folks to read a recent paper in the British Medical Journal. It just came out on remote access monitoring by the group at McMaster that specifically in the British Medical Journal talked about getting patients to this point, getting patients home, and then remote monitoring as another adjunctive way to ensure patient safety and ultimately evaluating patient outcomes. Using these approaches such as enhanced recovery are critically important for managing the critical issues, I think, Pascal, that we have to deal with, which often has to do with nausea, pain control, infection management, specifically wound healing management, and a host of other areas. So thank you so much, everyone. Thank you, Pascal. And once again, thank you to 3M for making sure that these sorts of events can happen around Canada and the world. Thank you so much, everyone. Have a wonderful evening.